everybody. I would like to welcome all the viewers in the BIC 2020, by Translumina. So today's session topic is plaque modification using ultra high pressure plaque modification device. I would like to welcome our moderator, Dr. Rajneesh Kapoor, Vice Chairman, Medanta.
Yeah, thanks, Pankudi. Thanks, and good afternoon to all of you. I think this is a very nice forum, one of its kinds, and I believe first of the digital conferences to be held, which is involving all over India and the global cardiologists. So it's going on for 3 days. Yesterday also there were some sessions, and today also we are all assembled here for very interesting sessions. And this digital conference is named as Best Interventional Cases 2020. So it looks like a future for us. It looks like that we are in for more and more such conferences because next 6 months travel is still uncertain because of the COVID situation. And I think this way also the interactions and academics we can really discuss in a more efficient, meticulous way and share all our real life cases and academic knowledge. So I'll go on for this session. First, I'll introduce the chairpersons. We are really proud and privileged to have our international colleague, well-known cardiologist, Dr. Florin Susuli. How to pronounce it, Dr. Florin? Dr. Florin Susuli, who's heading an interventional cardiology department, heart center at Lucerne, Switzerland. Welcome, Dr. Susuli.
Thank you.
Welcome. Yeah. And then we have our own very respectable, lovable Dr. Mehta from Mumbai. He's a well-known name in the Indian cardiology scene. We all love him for his versatility, for his innovative talks and orations, which we keep hearing at various forums. Dr. Mehta, most welcome. Yeah. And then we have a very good esteemed panel. We have a really, senior cardiologists to discuss the nuances, all the questions related to these topics. Dr. N.O. Bansal, who's heading the cardiology department at JJ Hospital, Mumbai. Dr. Bansal is with us. Okay, Dr. Ajit Menon, again a well-known cardiologist, a senior guy from Leelavati, Mumbai. Dr. Ajit, welcome.
Hi, thank you.
Yeah, Dr. P.J. Bhattacharya, who's heading a Guwahati Medical College Cardiology Department. Dr. Bhattacharya, is he around? Okay, maybe a few guys must be joining in some time. Dr. Ankush Gupta, a senior interventional cardiologist based at Hospital, New Delhi. And Dr. Uday Mahorkar is the director, Avanti Institute of Cardiology Private Limited. Dr. Mahorkar. So welcome to everybody here. And I think we are in for a very nice and innovative session. And we have a whole list of presenters here. I'll start the session by calling in a first talk of the session by our own Dr. Florin Susuli. Dr. Susuli, over to you for a master's view about this topic, the plaque modification by using a ultra high pressure plaque modification devices, balloons, scoring balloons or cutting balloons or rotablators. We know we have everything, but let's hear it from Dr. Susuli.
Thank you very much. I'll share my screen now. So I would like to I would like to share with you some slides about how we have treated highly calcified lesions with this ultra high pressure balloon since about 10 years now, actually. And this is cases from the last years. I know in India it's available only in the last 2 years, I think, but we have used it before. So I would like to structure my talk with why does actually PCI fail and show you that mechanics is very important. Then the next thing is, why does it make a difference which balloon you use? And then, of course, the OPNNC balloon, a short presentation, and then some cases. If you look back 23 years ago, Dr. Castrati presented this meta-analysis, and he demonstrated that actually many of the factors besides diabetes that lead to in-stent restenosis or thrombosis or target lesion failure are mechanical. So it's CTO, it's long lesions, it's short, it's small diameter, and of course, these are all mechanical factors and chronic total occlusions. So we have to do something. If we want to improve outcomes in PCI, we have to do something about mechanical factors. In the last years, with new stents, drug-eluting stents and newer generation of drug-eluting stents, we improved outcomes by improving the biological part. But I think we have still some work to do for the mechanical part of PCI. And if you look at one of the main factors why PCI fails is, of course, calcium. And I've had the pleasure to work in India several times with some of you as well. And I've seen how calcified vessels you have. Actually, you have much more calcified vessels than we do here in Switzerland. And if you use a balloon, a normal semi-compliant or even a normal non-compliant balloon for a calcified lesions, as you can see here, the calcium signaled with the 3 red arrows, then the balloon, the non-compliant, even non-compliant balloons will usually not be able to crack the calcium if the calcium is thick, and they will expand into the soft part of the vessel and cause these dissections. So we need to address calcium in a different way. And if you look at the different balloons, then you know that if you use high pressure with normal balloons, their diameter will increase exponentially, and this is dangerous because, again, it's very important to recognize or to remember that diameter cracks and disrupts vessels, not pressure. And I'll show you some cases. The unique part about the about the OPNNC balloon is that it's a double-layered balloon, which allows you to go to very high pressures by not exploding with your diameter. So your diameter remains quite stable. It increases in a linear fashion, even if you go to very high pressures. And you can see this on your angiogram. If you inflate the open balloon, I'm sure many of you have done it in the last months, then you see that actually even visually the balloon keeps the diameter, and despite the fact that you increase the pressure. This is an important case which I treated recently. So this man came in 2017 with a STEMI, and he was a difficult colleague of mine. I treated him, and they could not cross the lesion. The lesion was very difficult to cross, so they had to do rotablations. They used a 1.5 burr, made their way free, and this was, you can see here, the final result. So my colleagues were very happy with this because they were, after 3 hours, they were happy they got a stent down, and they said, okay, fine, let's leave it like this. I'm sure many others would have left it as that, like that as well. But the patient came back 3 years later, this time with a stent thrombosis. And you can see here on the right side, highly thrombotic, highly calcified as well. We knew it's a lot of calcium. So in this case, it was quite difficult to now expand the old stents. And what I would like to show you that I had to use a 2.5 OPN at 45 atmospheres and a 3.5 OPN at 45 atmospheres in order to really be able to expand these old stents. This was the final result from my side. And interestingly, I'll show you what stent boost actually showed. And here, and I hope you can appreciate it, the old stents were crunched in the middle. So this was the problem. That's why the patient had a stent thrombosis. And this means, and it's important to realize, only the fact that you use rotablation does not mean you get a good stent expansion. Pressure is needed for stent expansion, not rotablation or anything. I think rotablation is a great tool to allow us to cross balloons, but it's not going to guarantee stent expansion. This is very, very, very important. Let me show you some other case with you. 74-year-old lady with a calcified right coronary artery, very calcified. You can appreciate on the right side the OCT, and which demonstrates, now you'll see it here, a lot of calcium. So of course I could have used a rotablation here, but I said, let's try. If the balloon crosses, then I can do this with on balloon base. Luckily, the balloon crossed. Usually I use a Grand Slam wire for for such lesions because I just want to have a great support. And I was here on a radial and I did not want to go femoral in this case. She was an old lady. And after a 2.0 EZT balloon, which is a normal non-compliant balloon from Sys Medical, the same company which produces the Opian balloon, I felt, okay, I've made some space. I did OCT, which I showed you. And then I said, here is a lot of calcium, but it's not only calcium. The lesion looked very fibrocalcific as well. So I said, well, I'm not a fundamentalist. I can use also other tools besides OPN. For me, the OPN is always the center of treating a calcified lesion, but I can add rotablation, I can add cutting balloon, I can even add sometimes shockwave, but the OPN will always remain the center of this treatment for the patient. So in this case, I used a 3.0 Wolverine, cutting balloon, a novel cutting balloon from Boston. Then I use OPN 3.0 at 40 atmospheres. I call this cut and crack. So I cut the calcium, then I crack it with high pressure, and then implanted a 3.5 36 millimeter stent, and we post-dilated with a OPN. This was the result I got. And I was not happy with this result because although the stent looked open, the lesion tended to collapse again despite having put a stent in. So I said, well, I did OCT, I checked again, and I felt I have to enforce this with a second layer of stents. And this is the next important point. It's nonsense. If your balloon expands and then the lesion collapses again, then you need a second layer of stent. And I do this quite frequently. I'm wondering what you think about this approach. We can discuss it. So in this case, after I put a second layer of stent, I had a very nice result. I had no rupture, and I'm sure this patient has a very low risk of stent thrombosis. Do I say we should not use rota? Not at all. We should use rota if we cannot cross balloons. And I do that frequently. If I cannot cross a balloon, I use a small burr 1.5 to just create a channel so I can just quickly finish the case. Like in this case, very highly calcified. Then after 1.5 burr, I use the open 3.0, 35 atmospheres. Then this is what it looked like after 2 stents. I post-dilated with 30 atmospheres, and this is the final result. One could have post-dilated even more, but I think it was fine. And the good thing about such things, if you achieve enough lumen in calcified lesions, they actually have a good outcome. The problem that calcified lesions have restenosis or a high rate of restenosis is usually because we leave the stents underexpand. Let me just show you this result. This was 18 months later, and look what it looks like. So I think if you do a good job in the beginning, then this even very complex lesions will remain open. And just 2 more examples of patients on the left and on the right side. This is purely OPN based, so no rotablation, no anything, just pressure, cracking the vessel, and then having a good result. And also this one here, as you can see, post-CABG, calcified, post-stent, long lesion, very, very tortuous, difficult to treat. And I think such lesions you can only treat with OPN. You cannot use rotablation here. You cannot bring a shockwave balloon down. I think we need, that's why I am a very high supporter of this idea that the OPN NC balloon remains in the middle, and then we use the different tools to just add to OPN. But I think the OPN is very important for this. Just a small study which we did some years ago, which demonstrated that if we use semi-compliant and non-compliant balloons for lesion preparation, it's very important that you use, the study showed that you have to use non-compliant balloons for lesion preparation, because stent expansion, if you look after stenting, this was an OCT, you won't see a big difference just immediately after stenting. But if you post-dilate with the same pressure, same balloon size, you will find out that actually once you have cracked the lesion and you put the stent in, then it will be much more responsive to post-dilatation. If you left your lesion unprepared and unmodified and you put a stent in, then even high pressure post-dilatation will not give you a very good result. This is, you can read the study, it was published in Open Heart. So 4 common concerns before I conclude. people say, I don't use opium because it's bulky. Yes, it's a bulky balloon, but you need a proper wire to get it down, and you can prepare with a normal balloon before you put it down. Then I see people saying, I prefer debulking with a rotablation. You can do that, but if you want to debulk in a really big vessel, you need a 2.0 or 2.25 burr. And these burrs are not undangerous. And I think it's also, then sometimes you need also a higher French size. So you can keep the procedure simple. And I use the rotablation just to bring my balloon down. I hear people saying you must be perforating all the time. No, I think if you understand how to treat it and just go by the principle, downsize your balloon size, upsize your pressure you use, then you usually don't perforate. And even if it happens, then after you have cracked the lesion, you can bring a covered stent down. And then the other is, I'm afraid of high pressure inflations. Again, high pressure does not perforate vessels, diameter perforate vessels. So my final slide. Sorry, PCI failure is very often mechanical, so we have to address mechanical factors. And I think it's important to use good lesion preparation, because only good lesion preparation will give us good stent expansion. And I think if you give the patient a good stent expansion, then he will have a good outcome. If we leave the stents under expanded, these patients will come back sooner or later. And very important, as I said before, in calcified lesions, very often more pressure is needed rather than more diameter. And I think at the moment, at least, the opium and T balloon is the only balloon which allows us to go at very high pressure and be safe at the same time. Thank you very much for your for listening to me, and I hope you have some questions. We can discuss it. Thanks.
Yeah, Dr. Florin, this was really wonderful, very elucidating, and a fabulous talk. The message was very clear that a coronary bed should be prepared very aggressively, especially in fibrotic and calcified lesions. My just one question, and then I think I'll have inputs from a chairperson, Dr. Mehta also. Once you have done a good rota ablator with 1.5 burr, would you try getting a stent in, or are you mentally prepared just to go ahead with the OPN balloon, dilate it further, and then get the stent in?
Yeah. So when I use the OP, I never do stenting just immediately after rota, because sometimes the calcium is very deep. So just the fact that you can bring the stent down does not mean the lesion is prepared. And the second is, so I usually inflate the OPN balloon myself, because this is a balloon which gives you a one-to-one tactile feedback when you inflate the pump. So with OPN, I can feel when the calcium is cracked, then the OPN expands freely. Then I sometimes stop at 22, 24 atmospheres because I think it's cracked already. But sometimes if I have still a lot of resistance from the vessel at 30 atmospheres, then I really push it even further in order to really crack the calcium and prepare the bed very well.
Great. Dr. Mehta?
Yeah, Dr. Florin, so my question is, normally in our practice, what we do is we use an OPN balloon once we have seen that a lesion is non-dilatable. That means we first go with a normal balloon, and then when you find it's non-dilatable, then we go in for an OPN. Now, in your scenario, you suppose, for example, we have done a rota, and should we, as a standard, should we use an OPN after every rota, or should we first try and put in a stent, and if we don't deploy this, it doesn't expand, then we go in for an OPN? How would you advise?
I think very good question. In very calcified lesions, I think going directly for an OPN balloon shortens the procedure and makes the procedure also safer. Because the problem is, if you want to prepare well, you have to take an adequately sized balloon. And if you take an adequately sized non-compliant balloon and you go to high pressure, then you have a risk that the balloon will burst. If the balloon bursts, depending on how big the vessel is, a bit of air in that vessel is not always very well tolerated. So that's why in my practice, in my hospital, in such cases, we go directly for OPN. So we use only different balloons in very calcified lesions. If we believe that we cannot deliver the OPN, then we use a small size balloon to prepare so we can deliver the OPN. But once we can deliver OPN, we go with OPN in such lesions.
Dr. Ajit, would you like to give your input? What's your experience with OPN? Unmute, please unmute. Unmute. Dr. Ajit, please unmute. Dr. Ajit, you're not audible. Unmute.
I can. Sorry. We do have a fair amount of population with calcific vessels, and we do a fair amount of rotoblators also. We have been using, we first rotoblate, and then we have a habit of using scoring balloons in most of these patients following a rotoblation, and if the calcium load is pretty high, and this is much before the IVL balloons came in. Our use of NC, of the OPN NC, has been restricted to a certain extent in those patients where we don't get an adequate result with the scoring balloons after a rotablator, or we get an underdeployed stent after a stent deployment, after what we see as a visually adequate or a angiographically adequate or a IVUS guided or OCT guided image, which means that it shows that the calcium is well cracked. What is your view as far as use of scoring balloons is concerned in these patients?
So I, for a period of time, I used scoring balloons. NSA Alpha we used, and I had to remove it from the shelf because it just didn't help me. And now, more recently, I use this Wolverine balloon. I don't know if you have used that. And with that balloon, I achieve quite good results, always in combination with an OPN balloon. So this is, we are now actually collecting these cases, and we would like to also share it with the community later this year. Because I think the cutting balloon, at least this one is now for me the first balloon which you can deliver, because the problem is with the old cutting balloons, you could not deliver it down. It's much worse than an OPN balloon. So NSA you can deliver easily, but I didn't think that it makes much difference. And also when I looked after scoring balloon, and when I looked on OCT, usually I check with OCT, then I really didn't see a lot of work done by these balloons. I saw sometimes dissections, but not really the calcium fragmented. So that's, I'm a bit, I don't think that they are very good choice, but I mean, at the end, I think it's very important that you achieve a good stent expansion. The way to the stent expansion doesn't really matter. I think it depends, all of us work a bit differently. At the end, we have to leave the patient with enough lumen so he goes home and does not have to be afraid of a stent thrombosis or venous restenosis. I think this is the principle.
May I say something, Rajneesh?
Yeah, Dr. Mehta, we are looking for you. So we'd like to have your input regarding the usage of OPN balloon as a plaque modification.
First of all, Lorraine, we must understand and explain to our audience what does compliance mean. When you increase the pressure, and if the volume does not change much, that's a non-compliance. So rate of change of volume in relation to change of pressure defines compliance. Now, you correctly said that the minimum stented area, if you achieve 5 to 5.5, and if your stent is well opposed, you have done it. That's the end point. Now, you said, may I offer an optional approach? You said that you will use a rotablation 1.5 and straightway go to the high pressure balloon. Perhaps, maybe in my opinion, the different opinion is that once you have done a rotablation and you do the balloon dilatation, if I don't achieve full expansion of the balloon at 12 to 15 atmosphere, I will upsize the rota and go to 1.75 and 2. Question is that you said that you will, no, plaque modification. Long ago, I think Patrick Whitlow clearly showed that the plaque modification is 50% of burring is more than enough. All that you have to do is to crack the calcium. Having achieved the cracking, because I don't want the people to get the message that this is a complete substitute of rotablation. No, it is not so. Sometimes, even with it has happened to me for some time, and I went into with a very high pressure using a balloon. The balloon ruptured and I could not achieve what I wanted to achieve. So that was a clear-cut failure. Under such circumstances, I have to call the patient back again after a fortnight or so, do a rotablation and go ahead. And most importantly, the plaque modification and full expansion of balloon, if not achieved, do not venture to put the stent. That I think is disastrous. Unless you have a full expansion of the balloon, please do not ever think of placing a stent. Moreover, there are certain downsides of the high pressure also. It's not so simple. What about stent fracture? It has happened that you go very high pressure and you may get a stent fracture. 2, there is an overlapping areas. The two long stents, there are overlapping areas. And I think in such cases where I have to use overlapping, etc., I take an additional support of IVUS so as to strategize and to achieve most optimization. And by the way, I know very well that the penetration of IVUS all over the world except Southeast in Japan and Korea, very, very low. Therefore, Sujang Park has taught us how to optimize the stent without the IVUS. The lessons that we have learned from IVUS, we can extrapolate and use it in our practice. These are my comments.
Yeah, so Dr. Mehta, this was wonderful. I think for the sake of time, we'll move ahead with the next. There are very interesting case presentations here now, and I think we'll require your inputs and Dr. Florin's innovative ideas also as we move on. So I'll call upon the next presenter, Dr. Monique Mehta. Dr. Monique is presenting a case of plaque modification in acute MI. Dr. Monique, please.
Yes, good afternoon to everybody.
Please stick to your time. It's a time bound. Please stick to your time and we'll have some discussion. Okay.
Okay. So my case is my screen being shared by everyone?
Yes, it is.
Yes. Okay. So I am sharing my experience of OPN balloon. We've been using it for nearly a year now, and we had some cases in which this has been a real bailout, and this is one of those scenarios. So we had a 66-year-old male who came last year and had a recent onset of chest pain about an hour ago, and his comorbidities was he was grossly obese and he was hypertensive. When he came, he was in hypotension, he was in cardiogenic shock. He had to be intubated in the emergency. It was a very difficult intubation. Our anesthetists and the critical team had to really struggle because of his short neck, and they ended up breaking few of his teeth. But finally, they managed to get the airway in. His vitals were not great at all. Things were looking pretty bad. pH showed gross acidosis. His lactates were sky high. A screening echocardiography showed an LV of about 20%. And so he was in a very difficult situation. Intubation had been done and we shifted him to the cath lab. And this is what we put in an IBP, and this is what we saw. So the first took a right shot and it was non-dominant. There were some lesions there. And then the left side, as expected, showed a slow flow. There was some occlusion. The OM, the culprit was a large proximal 100% thrombotic occlusion. The IBP was in place, and thereafter we tried to wire the lesion. However, we had a real challenge, and there was a lot of calcification. In fact, the calcification is visible right throughout the LAD, and fortunately, we managed to wire the vessel. We were also fortunate to have gotten a 2 millimeter balloon, and we thought that things will be easy from here. But to our surprise, we found that this lesion was undilatable, and the balloon was not expanding fully. We took a check shot thereafter just to see what was the effect of our dilatation, and this is what we saw. There was a diffusely diseased LAD, and the proximal lesion was still as it was. So we changed the wire thereafter. We put another wire and then we changed it, and we were fortunate that we had an OPN balloon along with us, and we managed to get in a 2.5 mm OPN balloon, and which produced the desired result, and it expanded till we did about 40. And I'll just show that once again. Yeah. So this was the OPN balloon, and then, as mentioned by the previous speaker also, we saw that there was a lot of calcium all right through. So we used this OPN balloon and we managed to prepare the bed right throughout. Thereafter, this was the flows. Flows were much better. And then thereafter, the procedure was relatively straightforward. we managed to get in a distal stent, and then we had to cover the middle segment too. So then this is all thanks to the bed preparation that we had done earlier, that we were able to get in all our stents right through. And because of the diffuse disease, we had to cover right in the proximal aspect. And that was the final stent which we deployed. And I'll just show you the final pictures. So this was the final result. Generally, our intention should be, and is generally is, that we always should try and achieve good microvascular perfusion or circulation. Just opening it proximally and getting the epicardial vessel flowing generally would not give as good a result and outcome. So we spent some time pharmacologically trying to get the the smaller vessels also opened out. And we can see in the final shots that some degree of septals and diagonals have opened out, and there is some degree of microvascular perfusion. So the course was very, very stormy. He continued to be on balloon support, unstable hemodynamics, and in fact, at one stage we were thinking of mechanical circulatory device for support. Fortunately for everyone, thereafter he started gradually improving, and his balloon was taken off. He was extubated, and he was discharged a week from now. So just wanted to share this slide. It shows that patients with cardiogenic shock, having an opium balloon in your armamentarium can be a lifesaver, and it requires prompt interventions. We don't have time for and no time to be wasted. And there's, as I said in my thing, there should be a low threshold for plaque modification. Proper bed deployment is, as the previous speaker has also mentioned, is now that we have to get in multiple stents. And my aim is always that good distal and microvascular perfusion should be there before I take him out of the cath lab, to ensure that the post-cath recovery is also an optimistic outcome. And so with that, I'll close my presentation, and welcome your comments and questions.
Thank you, Dr. Manik. It was a really challenging case, especially if you land up with really fibrotic and calcified stuff in acute coronary syndrome or acute MI situation where you were not anticipating anything. You know, it's not an elective case, and suddenly you land up and feel that nothing is going. So yes. I think these devices are really handy. So I think let's take up the questions per two cases, not after each case. You know, let's have one more presenter, and then we can have questions with these two cases. So I'll move on to the next. Dr. Manan Anand. He's a versatile cardiologist practicing at Amritsar Nayyar Hospital. Dr. Manan, are you there? Ready with your case?
Good afternoon, sir.
Yeah.
Just a second. First, you have to unshare the screen.
Also, it's an important input to every presenter. After their presentation, they have to go to a stop share. They should stop share. Only then the next presenter can log in to share their presentations.
Can you see the screen, sir?
Yes, yes. Yes, Manan, it's visible.
This is a case. Sorry.
Make it full screen. Yeah.
Yeah.
Yes.
This is a plaque modification using a OPNC balloon in a patient of STEMI and in cardiogenic shock. And just to summarize it, it was a 65-year-old gentleman who presented with STEMI and was a severe LV dysfunction of ejection fraction of about 25% in cardiogenic shock, was on inotropes. And as the patient had ongoing chest pain, he was taken to the cath lab, and we did an angiogram, which showed a proximal LAD 100% occlusion with no flow. And just to summarize it, the procedure, we just wired the LAD using a fielder wire, and we did multiple attempts of thrombosuction, but still we couldn't achieve a good distal flow. We did a pre-dilatation with 2 and 2.5 balloons, and following that he was becoming unstable. We stented it with a 3.5 40 DES, but after deployation, we saw that the proximal part of the stent wasn't deployed, and we saw slow flow in the middle, and the distal LED was not filling, and the patient was becoming unstable with multiple VPCs, and we tried to open the stent with the non-compliant balloons, but couldn't work. We went at 20 atmosphere, but we couldn't open that. Immediately, we took a 3.5 10 OPNC balloon, and we deployed it at 37 atmospheres, and which opened the struts of the stent, and immediately, we could get a good TIMI3 flow there, and immediately the ectopics and everything settles, and STT changes settled. I'm just this is the basically gross overview of the angiogram, which showed a proximal LED lesion which was just wired, and thrombosuction was done. And then we just did a stenting of the proximal LED with the 3.5 40, and then we couldn't open the proximal part of the stent, and then it was a OPNC balloon which was dilated at 37 atmosphere and which could open that. So this was the proximal LED 100% occlusion. We just wired the LED, and we could see that there was a very slow flow in the distal part of the LED, and you just see the distal part of the LED. And I did a thrombosuction, and 3-4 times, multiple attempts of thrombosuction, but the distal LED was like this. I did a dilatation with the balloon, and then I stented it with a 3.5 40, and you would see that the proximal part of the stent is still not deployed, and it was not opening up, so we didn't go at a very high pressure, and this is what I saw after opening the LED. And then we did multiple attempts of dilatation with the non-compliant mini track, sphincter, everything we tried couldn't work. This is one screenshot of a very small 3.58 balloon which I'm trying to deploy, but the stent is not properly being deployed there. So I had to take a OPNC balloon, and we could see the dog boning in the balloon. Then I took a OPNC 3.5 into 10, and then I did a very high pressure dilatation at around 37 atmosphere, and then it could open the struts of the stent. See, this is a OPNC which is being deployed at 37 atmosphere, and then we could see good apposition of the stent and a good flow. And the patient, as was in cardiogenic shock, and is a very poor LV function of around 25%. Still, we managed to do it without IABP catheter. And the patient was off inotropes on the 3rd day and was discharged on the 5th day of admission. And he is on regular follow-up, and he is doing well till now. Thank you.
Yeah, so Dr. Mani, this was almost a similar case as Dr. Monique also shared. So acute MI, I think we can have 1 or 2 inputs here. So Dr. Florin, any experience of doing the rota in acute MI primary in such situations?
I just did it 3 days ago because I could not. Usually, I think if I can deliver the OPN balloon, then I don't use rota. But I had a case 3 days ago where I went on Impella first because fortunately here we have these devices. So I used Impella, which gives you a little bit of free time because by the time you put the Impella in, the patient will be free of pain. And then I used 1.5 Burr, and then I used OPN, and then I deployed the stent, which was fine. But I think the important point with these 2 cases, in my opinion, is that you, again, either you don't put a stent, that would be another option, to just you say you have TIMI3 flow and you see you cannot inflate very well, you are in the middle of the night, you say, okay, let's postpone it for tomorrow. I think that's not wrong. I do that sometimes. Or I think if you put a stent, then you have to somehow guarantee that it's, I mean, it doesn't have to be perfectly expanded in the acute STEMI. You can still correct this, but you cannot leave it like this last case we saw that, which was vastly underexpanded, because then with slow flow and an underexpanded stent, you will have a stent thrombosis. So that's not good for the patient.
Yeah, Dr. Mehta, one more input required from you. So do you think, once we land up with certain situations like this, pre-dilating with the aggressive 1:1 coronary size balloon would more lead to no flow situations? We're stuck.
Yes.
We're stuck.
Yeah. In fact, pre-dilating, even post-dilating, once you've got your hardware inside, even post-dilating also causes a lot of distal embolization. And so I would not. My strategy is always that, especially in acute MI settings, that it should be a quick in and quick out if you're having a good flow. If you're not having a good flow, that's where I persist with the patient and I use pharmacology. Once I'm ensured that I've got good expansion, and by that I have ensured pre-procedure, pre-stent deployment, that your bed has to be good. If your bed is not good, then you're in trouble. And Dr. Florin mentioned, or I think one of the speakers mentioned, that one can even just leave it after a balloon dilatation if you don't have good distal flow. But somehow I am not too comfortable. If I used a high pressure OPN balloon and if the distal flow is not good, I would, or the distal flow is good, but if I've used an OPN balloon, then I'm always worried that there may be some subtle dissection which is hidden somewhere. And if I leave him and at night he comes back with an acute closure, then we are in bigger trouble. So in an acute setting, if you've got a high pressure balloon dilatation done, and if your flows if you can get in a stent, and with pharmacological, I think we can, with perseverance, we spend some time, put in nitrates.
Dr. Monik, so we got your message. I was asking Dr. Mehta specifically. Dr. Mehta, your experience in this, where you are stuck with acute MI calcified lesions like this, which are undilatable.
Ashwin Mehta?
Yeah.
Mehta's.
Okay, sorry.
At least we are confronted with two contrasting features of a case. On one side, a thrombus where I am reluctant to high pressure, but the surest way of creating microvascular surging is the high pressure dilatation. On the other hand, I can't, because I have to get a proper bed. Confronted with these two contrasting problems is really a dicey situation. I generally feel that yes, do a minimum dilatation and try and aspirate. There are two trials, taste and pupil. Both are again using a thrombosuction, but there is a caveat. You have a large thrombus burden, you must suck. I think Dr. Manan Mehta's case is the proof that he went into cardiogenic shock with a big thrombus. Aspirate and do. And then I think with ablation.
We can continue these discussions further. Yeah. So next presenter is Dr. Y. Vijay Chandra Reddy. So Dr. Y. Vijay Chandra Reddy is a senior consultant interventional cardiologist from Apollo Hospitals, Chennai. Sorry. Sorry, Dr. Sanjay is the next one. Dr. Sanjay, are you there?
Yeah.
Yeah, Dr. Sanjay is a director interventional cardiologist, Fortis Hospital, Faridabad. So go ahead, Dr. Sanjay, with your presentation. Hi, Sanjay.
Yeah. Can you hear me?
Yeah, you're audible.
Just one second. Yeah, can you see my slides? I can't hear you.
Go ahead, Sanjay, it's visible.
Yeah, this is a case that I had done a few weeks back during the lockdown. This patient came with an NSTEMI and he had an angioplasty around 2004. I'll just show you the images. There was an osteoproximal stent in the circ and LAD, and distal OM had occluded this time. So my intention during doing this case was to do the distal OM first and probably think about it later on. I was not very keen in handling it in this scenario, but getting down the stent from the circumflex was getting hard. It was very fibrotic, so I had to dilate it at high pressures in the proximal area. So that's why I had to do a DK crush for this. The RC was also 100% occluded. He was not diabetic. I went down first with the wire, first with intention to treat the OM lesion. But before that, I had to dilate with a quantum balloon the proximal part to get something down there. This is the stent that went down there. And thereafter, it was inflated. And this was the final result for the OM. Then, because I had dilated with a high pressure balloon proximally, I then had decided that I'll have to do a DK crush at this point. But I could see the recoil. So at this stage, I took a quantum balloon, OPNNC balloon, because if I'm doing a DK crush, maximum chances of restenosis is in the side branch. And in this case, it was the circumflex. And ideal high pressure dilatation and adequate expansion of stent in this portion is necessary. After doing that, this was a stent placement. Keeping a balloon in the left main. The stent was deployed. Thereafter, I removed the wire and crushed the stent. Here also, I used that OPNNC balloon that I had first. And then I recrossed it and did a kissing balloon, the first kissing step. Of this lesion. Thereafter, I took a LED left main to LED stent, and it was subsequently deployed there. It's not running. The stent was deployed thereafter. The next steps of DK crush, I rewired and initially with a 2x12 balloon made an opening, but because I had the first kissing, so it was not very difficult in getting down, and with the bed preparation, I was able to open it. Finally, I post-dilated that stent with a 3.5x12 at around 24 atmospheric pressure, getting a good expansion of the circumflex stent. Thereafter, I post-dilated the LED stent with that 3.5 balloon, and ultimately the second kissing step, which I did, and finally the proximal optimization I did with a 4O balloon. This was the end result for it, which I thought was reasonable. So in my opinion, adequate bed preparation at high pressures in such situations is important to get good expansion of stents, particularly in such complicated cases. Thank you.
Yeah. Thanks, Sanjay. It was really challenging case. All compliments to you for managing it quite well. I think we'll come to the questions after the next case. I'll move on to the next one, Dr. Y. Vijay Chandra Reddy. He's from Apollo Hospitals, Chennai, and he's presenting a case where he has given a tag playing golf in the rocky terrain. So I like this title. Dr. Reddy, please go ahead.
Yeah, good afternoon, everyone. Let me put the screen on. Are you able to see that?
Your title is very catchy already.
I'll do a very short presentation. This is a post-CABG native right coronary artery graft occlusion refractory angina. You are looking the enemy straight in the eye. Densely calcified coronaries, two critical blocks, proximal and mid. And this enemy comes in many forms: spicules, nodules, pebbles, rocks, boulders, hillocks, mountains. Worst if it is in angulated and tortuous vessels. In the setting of an ACS, even more horrible. Difficulties at every step, suboptimal results, more maze, and depending on the nature and morphology of this enemy, we feel sometimes like we are playing golf in a rocky terrain, sometimes worse, like driving a limousine through a rivulet in the Rocky Mountains, and sometimes like riding a Harley Davidson in a rocky cave. And I'm sure all of you must have faced this. We have several tricks up our sleeve. What we do, go with better support behind, good support, guide extension. We use bigger force with the ultra high pressure OPN balloons or NC balloons, or better force with a specialty balloon cutting and sculpting. These are force-based approaches, but then some other techniques are there. This is strategy-based, where you use rotation or shockwave or laser. This is strategy-based. So with a good backup support, force-based, strategy-based, of course, if imaging is there, we can see what the calcium is. And if the calcium is all around, deep and long, we know we are with a bigger enemy and we need to crack it better. And if the balloon is crossable or not will dictate the options. So this case, I was trying the normal NC balloon here, didn't work. OPN 25, 28, it cracked. The OPN here, 35, 40, 45, no cracking. So even OPN didn't crack it. So what is it? Balloon is crossable, but OPN also is not working. I know if I have an IVL, that's it, but I don't have an IVL on that day. So that was a time before IVL was introduced into our country. So rotational atherectomy, that's what. So 2 rotas, again, NC doesn't open. Again, OPN 35, prepare the bed, stents, good. Of course, if IVL was there, I could have avoided rotablator and multiple balloons in the inventory. We know about the OPN and that was its benefits. Look at this critical mid-RCA dense calcific, again, another form of enemy. Looks like
YBC,
yes.
YBC, your screen is not seen. Your slides are not seen. We are seeing only you.
Wait.
Yeah, we are just seeing you talking. We are not seeing your screen.
How do I come out of that? I said share screen. See, share screen is on.
No, you are visible. Your screen, share your presentation.
Sir, click on share screen.
Share screen.
Then
Now
select the presentation from your box.
this is only the presentation is there.
Yeah, click on it and then click share button on the box. Right hand side you see share button.
See the save.
Go to Zoom.
Zoom, yeah.
Click on share screen. Yes.
Yeah.
Go to full screen mode.
Yeah.
Now we're able to see
Please
the
continue.
Yeah.
Now we can see that, Dr. Reddy, you can go to the slide. We have heard your story. So
yeah.
please,
So
come
this
to that
was it.
slide.
So calcium, we showed that, and then with the rota and then stents. And this mid-focal lesion there, again, I try the usual tricks, the NC balloon, even OPN balloon, 35, 40, no. It just doesn't give way at that one single point. Of course, again, force, no IVL, rota, stent, and IVL, of course, OPN for post-dilatation and good result. So force-based, the problem was it is non-selective, so you can produce barotrauma problems. With strategy-based, still there are two different strategies. One that might push the muck down, and it is also guide wire biased rotablation or IVL. So this is a classical case you were all alluding to before, acute MI, acute on chronic CTO. You find a epsilon RCA here, dense calcium all around there, huge superdominant cardiogenic shock, 1.7 triple vasopressors, VT, ventilation. You do the entire aorta is calcified. We do the classical CTO wiring techniques, Guidezilla, backup support, no balloon crosses. These are balloon non-crossable calcium again, acute setting, the worst calcium, and whatever little bit balloons go in, the balloons start rupturing there. And then 3 NC balloons rupture, OPN, 026 profile OPN also could not be crossed even with Guidezilla support. So we are forced now because even though we cannot get it, again, a bit of rota, in acute MI, and then of course use OPN balloons and Guidezilla based. Again, OPN helps us here because just cracking with doing the rota alone is just giving you some access only. So with OPN, we could get it. And this is a final thing. You can see the enemy here again, post-CABG, occluded graft to LAD, dense calcium, left main, and the LAD, the issue was this. It was a gross bend there, the septal deceased, and then nicely calcific all around, all the way here, calcium is there. Now we have better tools in our lab. We have the IVL, we have the OCTs, and this is what the OCT showed. As I said, calcium all around, thick and deep. We can see the, I'll show you the shots. You can see calcific nodules there. There are TICFA was there. The calcium thickness is almost 1.1 millimeters, and the entire length on the L scan is calcified. So all around thick, dense, you know the strategy here. Here we have, of course, an IVL balloon. So, and moreover, one more thing, important feature, you see the guide wire and the guide wire bias in the calcific lesion. If you use a rotablator, it will be a biased rotablation here. You won't get a modification of the calcium there. And here, that's what we had to use an IVL. We did it, and 2.5, 12, multiple cycles. And then post IVL, if you see the OCT, there are cracks everywhere. Here in the L section, multiple cracks there. And as you see the short axis, deep cracks as well. Deep, multiple, in some segments, there were 3 cracks as well. And you could modify the entire lesion there. So if you can see the short axis here, multiple fractures of the calcium. And then not only that, of course, there must be some compliance vessel, or the vessel also must have modified. So these are all the advantages of the IVL there, and 2 stents, and you can get a good result. So as you can see here, we have calcium in multiple ways. As we said, sometimes the NC doesn't work, OPNX. But if the OPN cannot go through like an acute situation, what we had to go in with a rotablation and then do the thing. If the balloon can cross, probably you can avoid too much of OPNs, because the OPN, what I've said and done, is a non-selective trauma to the vessel, barotrauma, whereas an IVL is more selective onto the hard calcific plaques. So depending on the inventory, depending on the case types, I think we have to choose, because as you all must have faced, the calciums we see are not one types. There are several types, and we can change the strategy from force-based to a strategy-based as per the scenario. And multiple times, it will be a mixture of all these things. Thank you.
Yeah. So Dr. Reddy, you have won the golf match. So you're the winner in the golf match. Okay. So I think the question which is coming from the audience, in fact, Dr. Hiremath is also there. He's also putting up 3 questions. The question which has come up frequently is why the perforation chances are low with even aggressive dilatation with OPN. I think I'll answer, but then let's take an input from Dr. Ashwin Mehta. Dr. Ashwin, if you're there, please be ready. So now OPN balloon is a double layered balloon. That is the reason at times it's more bulky to get the OPN balloon into a very fibrotic and calcified lesions initially. So it's a double layered balloon, and the spicules piercing the balloon, the chances are lesser as compared to the ordinary balloon, ordinary non-compliant balloon, I mean. And the other thing is it's absolutely non-compliant. Almost, it's the lowest compliance attached to OPN. It is not increasing in size at all. So that also reflects in lesser perforations as compared to other balloons which rupture. Now, most of the perforations which happen with the very high pressure balloons, once the balloon bursts, the jet of that, the jet which is produced because of the burst hits the artery and leads to perf. So that is not happening. Since the balloon is not bursting, the chances of perforation are low. So, but I think Dr. Ashwin, if you are around.
Yes, sir.
Yeah.
Can you hear me?
We'll have your input in this. In your experience, the chances of perforation with OPN?
No, I have never seen. I've seen rupture balloon. Balloon does rupture occasionally. If you go very high pressure, that too little fast, then the balloon does rupture. The other reason is that since it is totally non-compliant, it will not dumbbell very easily, and it will not damage proximally and distally. And you said very correctly, it is a high velocity pinpoint puncture of a balloon that creates a jet, traumatizing jet, which produces perforation and damage to the arterial wall. That does not happen because it is double layered. That material which will stand at the high pressure. That's the point.
Yeah, thank you. So Dr. Sanjay, it was again a very commendable case from you, and Dr. Reddy, you have shown a few cases which were really innovative and gave us a clear message. Dr. Reddy, you can stop your sharing so that we move on to the next one. Next case presenter is Dr. Malik. Dr. Malik Azharuddin, who is associate professor in Aligarh University, Uttar Pradesh. Dr. Malik, are you ready with your case? Is Dr. Malik there?
Dr. Kapoor?
Yeah.
I'm here.
Yeah.
This is Dr.
Malik.
Bansal here.
Yeah, Dr. Bansal.
Yeah, I can't share screen yet. I think the previous share screen hasn't been stopped.
Sorry, Dr. Bansal, I'll come to you after this. So I missed you. I think I initially called you. So after this, we'll have your inputs also as a panel discussion.
Okay, shall I start?
Yeah, Dr. Malik, please go ahead.
Okay, good afternoon, everyone. Although what I'm about to show has already been covered and it could be more of my experience of the same, but let's have it. So my case was a 65-year-old female. She presented with an anterior wall estimation with CHV, and she received thrombolysis with reticulase in an outside hospital about 6 hours from angina onset. And she was shifted to our center for a rescue PCI because despite thrombolysis, she had ongoing chest pain, persistent ST elevation. Although her CHV had reverted, when she presented to us, she was in class 2 with established hemodynamics with a blood pressure of 100/70 and tachycardia with heart rate of 110. CHV was not there anymore, but QRBB pattern with persistent ST elevation and ongoing angina was there. So we took her to the lab. The coronary angiogram revealed an LED lesion. The right areocaudal view, the iliocranial view shows it more beautifully, and we can see that there is some calcification here, and it's a tight stenotic lesion. Although we don't see obvious thrombus burden, so we decided based on the tight lesion to go ahead with the LED. There was some proximal circumflex plaque and some distal circumflex. There was also an RCL lesion, proximal 60-70%, which was thrombotic, and there is a tiny distal thrombus in the PLV, if you can appreciate that. So we also thought that the CHV might not be anterior wall related. It could be a dual sort of lesion. But since the LED lesion was clearly more pressing and more severe, we decided to go ahead with the LED PCI. We did NC balloon dilatation. The balloon seemed well expanded. There was no residual waste. But post NC balloon dilatation, we had this picture, and there was no reflow just by NC balloon dilatation. There could be two possibilities: either there was huge thrombus which we did not appreciate, or it could be dissection flap. Either ways, with NC balloon dilatation and no reflow, we didn't have a choice. We just stented it. We deployed 3.5 19 eluting stent at 20 atmosphere. Again, the stent expansion looks okay, but as we can see post stent deployment, there is some waste and some haziness. So probably there is some thrombus there, which was not very well seen. We gave some vasodilators, and post vasodilation looks better. In epicranial projection, there is a reasonable stent expansion, and distal flow is very well established with good TME flows and TMP grading. However, the iliocranial projection clearly shows that there is definite residual waste. We cannot leave this much amount of waste. So again, standard post dilation with normal NC balloon we tried. This is a 3.59 mm balloon. I prefer using shorter balloons because it delivers better pressures and better obliteration of any residual waste. But with this, there is some amount of waste which was there, and post NC balloon dilatation, it just looks the same. It seems like that NC balloon at 20 atmosphere didn't yield much. So now we really don't have any other choice. Pre-OPNC era, we would have just tried to dilate it a little more and just would have called it as that's the best we can achieve. But thankfully, with the availability of high pressure dilatation balloon like OPNC, this is a OPNC balloon. We use a 3.5 into 15 mm balloon. I would have loved a shorter balloon, but unfortunately, that was what we had in our shelves. And this is after dilatation with an OPNC balloon at 40 atmosphere. There is still some residual waste, but it looks better than before. And although we didn't do an OCT or anything, but I can guess that we would have achieved acceptable MLAs. And this still images, you can clearly see that as compared to dilatation with just an OPNC balloon, just an normal NC balloon, the OPNC did achieve a slightly better result. And this is the final result in RAO cranial projection and showing well expanded stent with good flows. I would like to emphasize this, but we are sometimes afraid of doing too much post dilatations in patients who present us with acute MIs. Of course, unnecessary dilatation should be avoided because they lead to slow flow because of distal embolization. But we should not be afraid of doing adequate post dilation, and leaving under expanded stent is much more hazardous than the risk of transient microvascular occlusion, which usually is very well dealt with vasodilators. Nitroprusside, if available, works really well. Thank you.
Yeah. So Dr. Malik, nicely handled. It is more of a fibrotic lesion rather than a calcific lesion. So Dr. Bansal, who has joined as a panelist, I think initially he wasn't there once I called, from JJ Hospital, Mumbai. We can have your input in these specific situations where more fibrotic lesions, especially a bifurcation or osteal. Do you think cutting balloon is better than these non-compliant balloons?
I would always first use the cutting balloon, because cutting balloon can give you good cuts, and then you can dilate afterwards with the NC balloon and get a good lumen. Unless along with the fibrotic there is calcification, then I would certainly go for the OPN balloon. So I'll share with you my short experience of 1 year. We had Dr. Susuli at our hospital 1 year ago to carry out a workshop. Since then, we have done the OPN use in about 25 balloons, in 25 patients, and we have found the results to be very encouraging. I believe that if your conventional balloon does not yield with the high pressures, then you should open the NC OPN balloon faster rather than use multiple NC balloons and have a problem of dissection and then resort to the OPN balloon. OPN balloon, of course, one of the limitations is that it has a high profile, so crossing may be difficult, and always please use a new OPN balloon. A reused OPN balloon is not going to work because it doesn't fold back. This is what I have learned. And if you have more dense calcium, particularly more than half the rim on the OCT, then it is better that you directly go with the OPN balloon rather than go with the conventional NC balloons.
Agreed. Dr. Uday, specifically once you have stented such high fibrotic lesions and there is some residual stenosis inside the stented segment, how aggressively should we keep chasing it to achieve perfection? You're not audible. Unmute, please. Unmute. Yeah. No, you're not audible, Dr. Uday. Okay. So we'll have one more presenter and then have further questions. Next is Dr. S. Selvamani. Dr. S. Selvamani comes from Madurai, Meenakshi Mission Hospital, Madurai. He's a senior consultant interventional cardiologist there, and he has an interesting case to present. Dr. Selvamani, are you around?
Yeah, I'm around.
Yeah, please.
Yeah. Can you see my screen?
Not yet. Yeah, now it's there. Now it's there. Please go ahead.
Yeah, sure.
Just make it a full screen.
Yeah.
Yeah, absolutely fine. Go ahead, Dr.
Okay.
Selvamani.
Yeah, today as we were discussing all this calcified lesions and difficult to treat lesions, we know that we have been treating calcified lesion for quite some time, probably so many years, and that calcium has always been a problem. And of course, today, what is the interest is we have new evolved technologies, which definitely probably will improve our clinical outcomes. See, we have so many gadgets. We have rota, orbital atherectomy, excimer, cutting balloons, coring balloons, super high balloons. There is OPN balloons and lithotripsy. So having all this, how to use when is really a very big question. And for each thing, there is a specific indication, and there are certain limitations for each of the thing. I will just give you a brief line. Basically, calcium, we can divide it as these three things, either superficial, nodular, or deep. Superficial calcium, if you can take the device, even balloons work, but many times it's very difficult to take your devices there, then probably rota or some ablative technique is very, very useful. And of course, nodular, that is calcific nodule, is ideal you treat them with ablation technique. And of course, deeper calcium, rota has no role. Probably you'll have to go with the balloons and then lithotripsy, which is a new addition today. So there is a proposed guideline like this, which I will just briefly say, if you can cross the balloon, then it's very easy. Probably you dilate, you try to get an imaging, and then decide whether it's a deep calcium or superficial calcium. And then we can decide on a therapy, whether to go with OPN balloon or with just NC or with lithotripsy, depending on the calcium thickness. And of course, if you cannot cross the wire, if you cannot cross the balloon itself, then is a problem. Probably you'll have to go with rota. And if you cannot cross even a wire, probably laser is an answer for that. So this is a rough guide. Practically, it may not be very practical to use this chart, but for a beginner or for it gives a rough guide how to use these devices. Our ultimate aim is that we should achieve at least 80% of stent expansion compared to the reference diameter. That is our main aim, so that we get better long-term results and try to avoid these complications of dissection and under expansion. So keeping this in mind, we just go for this case here. See, this is a case, a severely calcified lesion. You see in the angiogram itself, it is severe calcium. You can see the calcium even before the dye comes, and it is all around the vessel. So it's a severe calcium there. So I thought we will use all the gadgets available and then probably take a decision. I dilated this lesion with a 2-size balloon, and then I have done an OCT imaging here. OCT image clearly shows the thickness of calcium, which I will just explain it to you. So before that, we have a calcium score, which is we look at the angle, which is the angle, and then give a score 1 or 2, and thickness of the calcium as well as the length of the calcium. Each point you give, and the maximum score is from 0 to 4. Higher the score, probably your success rate with simple NC balloons may not be there. You will have to use more gadgets. And there are studies which have shown that with simple NC balloons, calcium thickness up to 0.24 millimeters, that is 240 microns, is very easy. But there are exceptional cases where I have used even for 800 microns only plain NC balloon and cracked. But those are all, but you will have to use a lot of balloons, you will have a lot of problems. But a general guideline, this is what is the guideline it says. And of course, many times, if the calcium thickness is less than 500 microns, probably plain balloon will be useful. And rota, beyond that, if it's a superficial calcium and thickness up to probably, according to this trial, it says around 670 or 700 micron thickness calcium can be treated well with rota ablation. Beyond that, probably we'll have to go with our new additions like lithotripsy. And now the basic indication rota is if you cannot track a device, probably you'll have to use rota. That is what is my thinking today. See, coming to this case, it's a calcium clearly shows OCT. The calcium score is 4 here, and the arc is almost 360-degree arc calcium there, and exactly 360 degrees calcium. And you look at the thickness, it is almost more than 800 micron thickness there, and length of this calcium here is almost 30 millimeter or plus calcium. So keeping this in mind, then I thought, okay, I will take a bigger NC balloon. And then I tried to take a bigger NC balloon. I couldn't track that balloon there. There was difficulty in taking bigger balloons there. Then I had no options. Then I had to go for a rota ablation. Then I used a 1.5 bar rota, and then I have done a rota. And after rota, this is the OCT finding. Then after rota, I could take the other scoring balloons and cutting balloons there. So I have taken 2 millimeter scoring, and then 3 millimeter score balloon and 3 millimeter NC balloon. And what happened is the MLA, which was 1 after 2 balloon, has come up to 1.59. And you can clearly see how the fracture looks here. And these are ablations. That is, when you do a rota, this is a clean shaven areas. You can see here, these are ablated areas. And this crack is basically due to the balloon. And this is because of the rota shaving, which has occurred there, which facilitated in taking our device inside. After this, I have taken a 3.5 NC balloon, but you look at that, in spite of doing rota and using 3 there, there is a dog boning of this 3.5 NC balloon, which was not yielding. Then I had to take a OPN balloon there. I have used a 3.5 into 10 OPN balloon and dilated and cracked this lesion at 35 atmospheres. So after this OPN balloon, you see here, the scoring balloon of 3.5 into 10 and OPN balloon at 35 atmosphere, that lesion cracked. And then the lumen in the OCT from 1.59, it came to 4.14. And we could see a lot of fractures there. And probably when you achieve an area slightly more than 3.5 or 4, probably that is the time you should take your stent and then deploy. And coming to this OPN balloon, as we were discussing now, it's a double layered balloon, and it's a unique balloon where pressure is transmitted evenly all over the calcium. And it is a very low profile balloon. The advantage of this OPN balloon is even at 40 atmospheres, the total growth of balloon is less than 10%. And there's a linear compliance because of the unique material. And what happens is there is the linear compliance of pressure exerted over the calcium and the wall. And this controlled growth definitely avoids dog boning. That means if there is no dog boning, chances of perforation and dissection is less. So this is the advantage of this OPN balloon. You look at this image here, when a normal NC balloon, what happens? Pressure is not exerted evenly and the balloon dilates unevenly, you get this dog boning effect. So this is the main reason for perforation and dissection. But in a case of OPN, you will never get a dog boning. You will have a uniform exertion of pressure, and this is how the balloon opens. So that is the advantage of using this OPN balloon in such cases. And of course, working range compared to that, it's a very comfortable balloon. Although I have seen some cases of balloon rupture, but perforation and dissections are not very common with this balloon, even at very high pressures. And remember, when you use an OPN balloon, avoid polymer coated wires, especially Fielder XT or Whisper. Why? Because I'll tell you the reason. Because with high pressures, this balloon or this wire can get stuck to the balloon, and it is difficult to remove the balloon out. Only option will be you'll have to remove it along with the wire. So to avoid that, to avoid this complication, avoid using polymer sleeve wires. And of course, for distal crossing, use extra support wires like Grand Slam. And if you are using this OPN for pre-dilatation, use one size lesser, that is 0.5 size lesser compared to the vessel diameter. If you are using it for post-dilatation, 1:1 ratio is ideal recommendation. And we need to use it with a special inflation device, which has an atmosphere, which goes up to the atmosphere up to 55 bar. But normal inflation device, we do not have it beyond 28 or 30 atmosphere. So these are some specific points which you should remember when you are using this OPN balloon. And once you reach 20 atmosphere, go slow with your inflations. So now what happened after this OPN balloon, in our case, you see the beautiful fractures, and then area has grown from 4.14 to 1.59 to 4.14. And then we know that this is the time to stent now. So I have measured the EL to EL diameter also. We know that EL to EL is 4.4. So I should not exceed my NC balloon beyond 4.4 or 4.5. That is the main guideline. I have stented with a long stent, 3.5 to 38 as a stent there. And then after that, I have done a OCT. You see here, in the distal half of the stent, it is almost 100% stent expansion compared to the referral area. And then coming to the proximal, although it was a good expansion, we had an area of around 5.7 in the proximal half. But when compared to the reference segment, it was almost around 45% area stenosis left there in that minimal stented area. So I went ahead with a 4.5 NC since I knew that EL is around 4.4, and I have achieved an area of 7.09 in the proximal LAD without any dissection there, no perforations, and with uniform stent expansion with very little asymmetry. And this is the angiogram. It looks like this. And you can see this basic summary. We had to use so much of devices and probably to achieve an excellent result without much of complication. Thank you. I think I'll stop here. We'll not discuss about this nodule now. Thank you.
Yeah, really wonderful, Dr. Selvamani. It was a good elucidation of all the things attached to OPN balloon. In fact, some of the points are missing. You covered it all actually. So, Dr. Ajit, are you there? I'm just asking one more question. Now, suppose on pre-dilatation, as Dr. Selvamani mentioned, that we can take 0.5 lesser than the coronary size. If on that also it's not going away, would you like to go with 1:1 ratio on pre-dilatation? Dr. Ajit Menon.
I think a couple of things. One is that our basic aim is to achieve an adequate bed. So if we use a non-compliant balloon, which is 0.5 size, lower than the vessel size, and it doesn't open, I would rather go in with some of the plaque modification devices that are available. I mean, if it is heavily calcific, I would probably go in with a rotor. If not, go in with a cutting balloon or a scoring balloon if you feel the lesion is very, very fibrotic. And of course, the OPN balloons also, because going in with a 1:1 for the size of the vessel without imaging is something which is a little risky, because the risk of perforation goes up very high. Because you need to understand one thing, and I think Dr. Puchili also showed it in his first few slides, that most of the so-called non-compliant balloons, after a certain amount of pressure, become much more compliant. They are probably semi-compliant after a certain limit of pressure. That's something which we need to understand. So that's where the use of 1:1 sizing of non-compliant balloons beyond a certain point would, and especially if the lesion is dog boning, would be a risky proposition. And that's where look at alternative balloons, scoring balloons or cutting balloon, or use of OPN balloons. Or if you're comfortable with a rotablator and the lesion is calcific, your threshold for using a rotablator should be pretty low, because our basic aim is to modify the plaque with least amount of damage to the intima and get an adequate bed for deploying the stent. Because if you go back to the basics, our complication rates and restenotic rates are much more higher the more injury we cause to the vessel. So we have to minimize the injury, at the same time try and get an adequate bed so that the stent is well deployed. And as Dr. Selvamani showed, I think with the use of imaging, our use of higher size balloons is probably going up a little bit, because if you look at it on an angiography, you would dare not go beyond a 3.5 or 4 millimeter balloon under these circumstances. But the imaging gave you an idea that the EL to EL is so and so. So you are much more confident in going up to those balloons. So again, that's where the use of imaging comes in, where probably what you see on an angiogram may not be actually what is the actual size of the vessel.
Absolutely, I concur with this, because angiographically what you think, imaging wise it may be more, mostly. So Dr. Uday, I asked you a question just prior to this. I think you were not audible. Just try if you are audible again. The question is, once a stent is placed and there is some residual lesion, say 30%, 40% still residual, or 20% residual, whatever, would you really chase it to the perfection? There is some issue with the audio, Dr. Uday. Okay. Dr. Florin, I think we'll have your input. How aggressively we should chase post-stenting the residual stenosis? Unmute, please unmute.
Yeah. So in cases where I see angiographically an underexpanded stent, in those cases I usually do imaging, which is in most cases OCT, because I still aim for angiographic perfection, but I want to have a safe angiographic perfection, because in fact, very often, if you have implanted a 3.5 stent and the lesion looks angiographically underexpanded, then your diameter is not 3.2, it's usually 2.5 or 2.6, because you have actually maybe overestimated the diameter of the vessel. So in such cases, I think, okay, if I use a 3.0 OPN balloon at very high pressure, at the max I will reach is 3.3. So I am way below the safety, above the safety margin. So I say, okay, if I have a 3.5 stent which looks angiographically underdeployed, I take a 3.0 OPN balloon and go to 45, 50 atmospheres and really crack this. Afterwards, you can take a normal NC balloon and expand it a bit more. But I think with this approach, I have achieved quite a high standard of safety in our lab. So we don't have, if we use imaging, even if we aim for angiographic perfection, we don't rupture the vessels. However, if you do it without imaging and you just take the balloon, the same size you use the stent, you say you use a 3.5 stent, it looks underexpanded, you say you take a 3.5 balloon OPN and you expand it fully, then you get you can get a perforation.
Dr. Uday, please try again if we can listen to you. No, I'm sorry, there is some issue. So I think let's move to the next presenter. I'll try Dr. Uday again. Dr. Abhijit Palchikar, the bailout
yes.
OPN and C. Dr. Abhijit, are you there?
Yes, sir, I'm there.
Yeah, welcome. Welcome, Dr. Abhijit. He's from Sahyadri Hospital, Pune. Welcome. Please go ahead with your presentation.
Sure. Okay. Can you see the screen, sir?
Go ahead, please.
Yes, we can.
Yeah. The thing I learned from the OPNNC from the initial days when it was not introduced, or it was just new in the India or Pune. I came across a case, 65 years old male, non-diabetic, non-hypertensive, presented with non-ST elevation macular infarction, and basically angiography revealed long LAD disease, disease in diagonal, non-dominant circumflex were totally occluded, and RCA was dominant and clean. The surgical option was obviously ruled out by relatives, and though the LAD was diffusely diseased, the significant calcification could not be observed on the fluor. It was a slight calcification in the proximal segment. You can see the long disease in the mid segment and the distal mid segment was okay. So this is another RAO cranial view. You can see the calcification in proximal segment, but the disease segment doesn't show that much calcification, as we don't have any imaging modality in this cath lab, and that's why I thought instead of rota, let us go ahead with the ballooning and stenting. Initially with the ballooning in mid segment, you can see a small stent was put here in the tight lesion. Balloon did not give any problem during pre-dilatation. It was fully open as long as the mid segment and the lower mid segment is concerned. We thought calcium is not giving much trouble. Let us finish in 10 minutes, and forgot that calcium on fluoro is not accurately estimated, and we didn't had any imaging modality as such. So we took 2.75 stent here in proximal segment, and I thought from cover from normal to normal segment. But you expect a trouble whenever it is not expected. And when I inflated the stent, you can see the proximal segment here is not well expanded. As per the traditional methods, I went with NC balloon with quite 20-22 atmospheres. It was not giving away. So I ultimately underestimated the calcium there, and I could not dilate with the non-compliant balloon. So maximum ballooning, it could not open. I started with tirofiban and rest on the luck, because OPNNC was new on the block, and I never tried, and going to like 30, 35, 40 atmosphere was a little scary. So I never tried that, and the patient was shifted to ICU. After half an hour, patient developed chest pain, ST elevation, and he was again brought in the cath lab, and sheath was in situ. As you can see, the inflow of the proximal stent is not opened up. So that's why everything started to slow down. So he had a thrombus here after the stenosis there, and a TIMI 1 or 2 flow after tirofibanol. But with little ballooning, the flow started, STT settled, and I had little time to think what is try to do. But then I thought, okay, let us try with the OPNNC balloon. It was new for me. So I said, okay, let us try with one size smaller, 2.5, to go with for the dilatation of the stent. But small NC balloon 2.5 could not cross the lesion. It was not passing through that neck. I thought the balloon that has, as Dr. Bansal rightly said, the strength of balloon is so much that it must not be that deliverable. It must be thick and stiff little bit, not deliverable. Or then I thought it might need more support, or it needs to be more coaxial. The first thing I tried with the body wire, but it failed ultimately. And then I thought probably it needs a little extra strength for the pushing. Then I took a guide Zilla. I pushed it just proximal to the stent, crossing the first calcification, and with little push and coaxiality, I could pass the lesion easily. After going to 20 atmosphere, then gradually I went up. I had to go up to 45 atmosphere to completely open the lesion. And this is how the final result looks like. Everything went smooth. The flow was TIMI 3, and everything settled down. Hemodynamics were stable. So as Manos Bricalis has recommended in his, you see, when we go for a pre-dilatation with various modalities, we have got rotablation there, cutting balloon there, scoring balloon is there. But when we have got unexpanded stent, we have got very less options. The options they have given is use shorter balloon at higher pressure, non-compliant balloons. Smaller 2 balloons method is also described. It's supposed to give a more radial strength. I never tried with, and obviously with the body wires. The modified balloon like angiosculp and cutting balloon are going to be used pre-dilatation. They are not going to be very useful when you are using the post-stenting lesion. And there are chocolate balloons described. I could not find much about the thing. Laser obviously not an option here in India, not frequently available. Atherectomy is described orbital for the old stents only. Rotational atherectomy is not a official or the on-shelf indication for the stent, although some have described they use the rotational atherectomy for the post-dilatation of the stent. But then again, the stent material going in the microcirculation is a big problem. Another method Manos has described is subintimal tracking and then crushing the balloon. But this is again a little difficult to understand, because once the balloon is, the stent is not dilated, crushing it across the lesion and then putting another stent becomes very problematic. And usually this type of situation, patients are not that stable to go for a CABG, especially hemodynamics which are not stable, and ST is elevated, and there is slow flow, and patient is on lot of antiplatelet agents. And intravascular lithotripsy has come up as a new kid on the block, but still the role of
sorry, Dr. Abhijit, I'm interrupting. I think we got your message loud and clear, and the case was really good. So that's where Dr. Mehta was initially pointing out that one should not venture a stent until the bed is absolutely prepared. So I think we have further more questions from the audience coming up, and we'll have questions regarding your case after a few presentations more. So I move on to the next case, but there are many questions coming up from the audience, and one question is coming from Dr. Nishit Chandra, which I will put it to Dr. Ashwin, but we'll discuss it after 2 or 3 presentations so that we have some time for discussion after this. Dr. Ashwin Mehta is there?
Very much there.
Yeah, so I am giving you a question so that we discuss after 2 or 3 cases. He is asking, so what exactly we all want to know. Please let us know how to decide between cutting balloon, IVL, OPN balloon, or rotablation. So how we can pre-decide from a case. So I am giving you a question now, and then have few presentations, and then we discuss. So in the interest of time, I'm moving on to the next presentation. Dr. Siddharth Mani. Dr. Siddharth Mani, are you ready with your presentation?
Yes,
he's an interventional cardiologist from RTI Hospital, Kolkata.
Very good afternoon. Presently, we are devastated with a super cyclone, and for the last 22 hours, we don't have any electricity and internet and everything. So I have just prepared a sketchy slide to fulfill my commitments, and I'm sharing that with you. We have already discussed about the OPNNC a lot. So can you see my slide? Can you see my slide, sir?
Yeah, we can see.
Okay, so
very well visible.
This is a case. Yes, sir. This is a case
Make
where
it full
I had.
Screen, please. Make it full screen.
Okay.
Make it full screen.
So this was a case where I had to treat a long segment calcified LED lesion, and ultimately I had to use a high pressure modifying OPNNC balloon and to tackle it, and ultimately had to put in a long taper stent. So this was a 69-year-old male who suffered from an inferior wall myocardial infarction 2 years back, but at that time no intervention was done, probably because of the negligence from the patient side itself. And after 2 years, he presented with a chronic stable angina, which was CCS class 3. He was a diabetic smoker, suffering from COPD on regular inhalers, and he was getting the maximal medical therapy, AC inhibitors, beta blockers, and 2-3 anti-anginas. So this is his ECG, which showed at that this was a ECG during his previous attack during the MI, and this time he presented with this echo to us, which was showing a akinetic inferior wall with ejection fraction of 40% and a mild MR. This was his angiogram, which showed a long segment calcified LED lesion extending from prox and mid up to the mid-distal junction, and you can see some retrograde flow into the RCA. The RCA was dominant, which was totally occluded from the mid part, and from the echo it was showing a completely akinetic inferior wall. So he also had few lesions in the LCX, but it was a non-dominant vessel. So we thought of intervening only into the LED so that he could get rid of his angina at present. So initially we took a Ramshaw intermediate wire because we did not expect to use a OPNNC. Otherwise, I would have chosen an extra support wire like Grand Slam or something else. The wiring was a bit difficult, but ultimately we could manage normally. So initially we thought of creating some space because I anticipated a very tight lesion in the mid-distal junction. So I gradually started with a graded balloon dilatation 1.2 millimeter NC first to create some passage. And I dilated all throughout the prox and mid LED with 1.2 millimeter NC balloon. And then I took a 1.5 millimeter NC balloon to create some more passage. And this was the graded dilatation, followed by I could create some space in the mid-distal part, which was really tight. And now I took a larger diameter balloon, which was a 2.5 normal NC balloon. So this was more or less, I thought that the dilatation in the throughout the LED was adequate, and maybe we could we could negotiate a stent, but in the angiographic view, it was still showing that the mid-distal junction was looking very tight, and it was actually a bad bed preparation. It was inadequate bed preparation, and I did not have a provision of rota because it was a government-sponsored case, and we did not have the permission prior approval for rota ablation. So at that time, I had to take the only option available at that time in our cath lab, which was usable, was a OPNNC balloon. So that was a 2.5 millimeter into 10 millimeter OPNNC balloon, and I was mainly targeting the mid-distal tightest portion, and I went up to 35 atmospheres. And as I have taken the OPNNC balloon, I did a throughout dilatation in the prox and mid part in the LAD, and post dilatation, after the pre-dilatation, you can see that the mid-distal junction has now opened up, and there was some dissection noted. So dissection at that time in this situation was a welcome thing for me, because that would ensure a better stent expansion. So now I thought of taking a long tapered stent. It was a 2.75, 2.25 into 60 millimeter stent, which could extend up to the distal junction from proximal part. So otherwise, in such cases, I often take a guidezilla prior before introducing the stent. But I thought that because there was a dissection and quite adequate expansion, I thought that the stent could pass easily, and that had happened. There was not much difficulty in passing in the stent. So then you can see there was a more or less uniform and adequate expansion of the stent throughout, and this was followed by a post dilatation with a 3 into 12 millimeter NC balloon. I did not use OPN here because I had to expand the proximal part a little more, so I preferred a 3 millimeter balloon so that I can make it the 2.75 proximal stent into a 3.25 diameter. So this was the post dilatation, and this was the final result, which to me seemed quite decent and adequate with distal TB3 flow. So this is my case, sir. Thank you. If you have any questions, sir.
So no doubt, where rota is not available, or expertise, or some issues with the infrastructure is there because deficiency of rota. So OPN works there. So OPN is equivalent to rota in case it is not available, almost. That's what we can actually say about OPN at the moment. Doctor, audio was not working with Dr. Uday. Can we try Dr. Uday's audio once again?
Yeah.
Dr. Uday, are you there?
Yeah, I'm here.
Yeah, now this audio. So, Dr. Uday, I asked you a question, we had an answer. So, one, where there is a difficult maneuvering OPN balloon down. So what are the things we can do? We can have a buddy wire in, we can try to have smaller balloons and then get the OPN balloon. So let's have your input once it's difficult to get a OPN balloon down to the coronaries because of fibrotic lesions.
Sorry, please repeat the question.
I'm saying there is a fibrocalcific lesion and we cannot get a OPN balloon down. We are facing a resistance. So what next? Rota is not available. So how can we have a solution to this troubleshooting where we can get a OPN balloon down and start dilating aggressively?
We'll have to obviously take smaller size NC balloon.
Okay. So one, we can go ahead with the sequential.
And maybe I will take angioscult.
Yeah. Okay. So that's it. I think we move on to next two presentations and then have questions and answers after this. Dr. Sachin Hundekari. So use of novel high pressure NC balloon for resistant calcific lesions. Dr. Sachin, are you there?
Yes, sir. I am here. So this is a 70 years male who is diabetic and hypertensive.
Your slides.
Yeah. Yeah, can you see now? Yes. So this is 70 years male presented with class 3 angina who is diabetic and hypertensive, and angiography was done. It was showing critical calcific and tortuous long segment lesion of RCA. So you can see that in this, there is tortuous and long segment calcific lesion of RCA, and other coronaries were relatively normal. There is proximal bend and calcification. So initial choice was rotablator, but as we are not doing too much of rotablator, and as we know that sometimes rotablator burr can be trapped inside, sometimes we cannot take away the rota balloon down, and so that's why we thought that this might be the high risk case for rotablator. And a few days before, we just came to know about this open NC balloon. So we thought that rather than using cutting balloon, which are there on the shelf, but difficulty in taking down once the balloon is ruptured, and with scoring balloon, the efficacy is limited. So we thought that rotablator is the first option, but with this tortuosity and calcification and long segment lesions, we thought we can go ahead with the open NC balloon and try it out. So this was our first case. So after discussing pros and cons with the relatives, we decided to go up with this open NC balloon. We took JR guide. We have not taken AL or extra support because I thought that it might engage too deep and it can cause dissection. So we thought we can take one buddy wire. So we wired the lesion with BMW with one buddy wire, which was cyan blue. So after negotiating with one wire, it was difficult to pass the new balloon. So we have to dilate sequentially with 1.1, then 2 mm, then 2.5 and 2.75 mm balloon throughout the length of RCA. We are contemplating that during this procedure, as it was the calcific and tortuous lesion, patient may develop hypotension and bradyarrhythmias and heart blocks. So the temporary pacemaker was in situ before the start of procedure. Then we dilated the lesion sequentially with NC balloons first, and we have ruptured almost 3 balloons during the procedure. One of the balloon we used was open NC, which was ruptured in the mid segment, which was 3 into 15 mm. Then we took one buddy wire, and then we dilated with 3.5 mm NC balloon, and after the pre-dilatation, in the second pre-dilatation, we had to use 3.5 into 15 mm balloon, and we went up to 14 atmosphere, which was ruptured. Initially, we were skeptical to go for high pressure, but the lesions were not yielding, and we had a confidence that vessel size was around 3.5 to 4. So we can go with 1:1 dilatation with high pressure, and luckily it doesn't cause any rupture and everything, and the patient has transient heart block and hypotension, which was managed with IV fluids, and temporary pacemaker was there. So the distal part of the lesion was covered by 3 into 34 mm onyx stent. We was able to cross it after using 3-4 normal NC balloons, plus we used open NC balloon, which was initially difficult to pass without doing adequate pre-dilatation. So after this, we can negotiate the second stent also with 3.5 into 34 mm onyx stent. But the third stent was not going inside because of the angulation, plus the stent edge was there, which was resisting the entry of the stent. Then we again took another open NC balloon and opened the lesion to the fullest. It's also 3.5 into 15 mm NC balloon. And afterwards, we can able to cross the third stent. After this, we post-dilated with 4 into 15 mm open NC balloon, and the result was pretty good. During the procedure, all the 3 stents we put without much hazard, and the patient had good result. We want to have image guidance, but there was not. It was not available. So with the open NC balloon, that this complex case, and we can able to finish up without rotablator. So already the rotablator we have described with the dog boning effect of other balloons, and reservations about cutting balloons and scoring balloons. So I think in such case where we don't have rotablator or rotablator is risky, we can have this option where we can finish the case with open NC balloon. Thank you.
Sachin, that was a good case. Only thing which I can add upon is, considering Guidezilla, because there is an awkward calcified bend.
Yes.
That was causing a problem. So that would have also helped in getting the stent down. So, but nicely done. Thank you. So we move on to the last case, and then we have 3 or 5 questions to all the panelists. I'll try to engage all the panelists again after this presentation. We move on to the last presentation of this session, Dr. Vivek Mandurke, plaque modification with the high pressure NC balloon. Dr. Vivek, are you there?
Yes, I'm here, sir. I'm audible, sir?
Yeah. Dr. Vivek is from Marneja Heart and Multi-Speciality Hospital, Nagpur. Dr. Vivek, please go ahead.
Yes,
5 minutes for you.
Yes. Thank you, sir. I'm showing this experience of 2 cases where we used high pressure NC balloons. This is the first case where we used 78-year male hypertensive post PTCA. So admitted with ACS, and he was having in-state restenosis in mid RCA. So this was the case. We can see there is a stent which was 1 year back placed. So there was ISR. So initially we dilated with 2.5 NC at high pressure. Then we had done IVUS. We don't have the videos. We mistakenly deleted. I have some snapshots. So this was the under expanded stent. We can see here. It was 3 millimeter stent, so undersize as well. So we again went in the high pressure balloon, and this is the OPN NC balloon 3.515. We use this at high pressure around 35 ATM. So with adequate pre-dilatation, after adequate pre-dilatation, this was the picture. After we decided to stent with 3.5 millimeter stent, the artery was looking 3.5 to 4 millimeter.
Yeah.
Yes. So deployed at 18 atmosphere. Again, post dilated with the same NC balloon, 3.5 OPN NC balloon of 3.5 millimeter, followed by 4 millimeter of regular NC balloon. And this was the final picture. And the IVUS showed that there is adequate dilatation, and we achieved good MLA. And this was the final shot. So after this, this is the second case. This was our second experience with OPN balloon. We done this case with the proctor. So this 86-year male, ACS and syncope. So patient was high risk because of his 86 years age, as well as moderate AS was there, and the patient presented with ACS situation. So his angiography was this one. Highly calcified lesions were there, and this was the left main. We can see there is a left main tight left main ostial stenosis. We can see there are lesions in the LAD as well, but these are not flow limiting. So we kept with the option of medical management, PCI versus CABG. So obviously CABG was not an option because it was very high risk, and REAL is also not ready. So medical management also not good option because he was it was in ACS situation. So we opted for PCI. So definitely PCI versus protected PCI. So protected PCI will be the better option for him. So among that also, rather than total revascularization, we thought about left main angioplasty, which is a flow limiting, and we want to keep patient angina free for this patient. And again comes the plaque modification strategy. So the rotablation, OPN, NC, these were 2 options in front of us. So with Impella, we started the case. Initially, we thought that rather than rotablation, we will see that how is the NC balloon dilatation, how it gives feel of the lesion. So with this 2.25, the NC balloon easily crossed over the grind slam wire. So we dilated at high pressure. And after that, we thought that we'll go ahead with the OPN NC balloon. So 2 in OPN NC balloon we used, 3 and 3.5. So we went at high pressure, 35 to 40 atmosphere for 10 seconds. So both balloon we used, 3 and 3.5. So gradual dilatation we are done here. So we got good result afterward. We can see that open artery without any complication. So this is the 4x9 stent we placed here. So there was a adequate shaft length was there, so we thought that we can place stent only into the left main, need not to go into the LAD. So after you can see some waste was there. So again, post dilatation then with 4/6 NC balloon at high pressure, and there was we can see good expansion was there, and stent boost also shows there is adequately expanded. And after this, we'll stop this case on this note. We already discussed about the OP and NC balloon. Thank you.
Thanks, Dr. Vivek. Both cases were really good and challenging, and you managed it quite well. So I think we, with this, the presentations are over. We have few questions coming from the audience and certain things which we can reinforce to have the best outcomes. One question Dr. Shirish Hiremat from Pune, Ruby Hall is putting up is, I'll put it to Dr. Ajit. Dr. Ajit, can you, how many times you can reuse this OPN balloon in a single case, of course? ETO, we are not talking.
See, once the OPN balloon is unfolded, it becomes difficult to track back into a tortuous lesion. If it's a straightforward lesion, I think there's no major issue in tracking that balloon down, and there's no limitation of the number of lesions that you can dilate in the same setting with an open balloon. The only challenge will be that because it's like any bulky device, you will have a challenge of getting it through certain lesions. But again, you may have to pre-dilate the lesions or pre-treat those lesions if they are difficult to treat, and you can use the same balloon in multiple lesions, because the compliance doesn't change. Once the balloon is dilated, the compliance doesn't change.
Dr. Florin, can you put a light on the fact that how we can rewrap OPN balloon to be reused in another vessel in the same patient? Please unmute. You're not audible. Please unmute.
So there's two ways. One, the simple way to do that is usually to just inflate it again in the catheter before you enter the vessel. And this helps most of the times. The more complicated ways is a bit difficult to explain because I don't have this and I don't know how to name them in English, but you have this wrap of the balloon, which you can actually put the balloon again in the original wrap and then inflate it there, and then it would sometimes fold the balloon again. However, I think very often this is not necessary, because if you use a guide liner, for example, or a guidezilla, then even the reused OPN you can bring to the lesion down again, because you will avoid friction. So I think this is the three ways to do it. But yeah, maybe CIS or Translumina can do a short video on how to rewrap or refold the OPN. This would be helpful for people.
Yeah, I'll come to Dr. Uday again, because of the audio issue, he was less involved in the panel discussion. Dr. Uday, the same question is being asked by many of the guys sitting in the audience. Dr. Hiremath also pointed out this question in that desktop. If it is a circumflex ostial lesion and we're preparing a bed, would cutting balloon is better or a OPN balloon? I mean, if you have to choose between a cutting balloon and an OPN balloon for an ostial lesion. Please unmute. You are muted, sir. Dr. Uday, you are still muted. You are still muted.
Yeah.
Yeah.
No. I know why you are asking this question, because ostium of the circumflex is supposed to be Achilles heel of the intervention. It has very high chance of recurrence. So dilatation, pre-dilatation of the ostial circ is very, very important. And many times it is a very angulated vessel with 90-degree angle to the left main. So the negotiation will be very difficult with OPNC, I think. So I will prefer to try first balloon palpate with the help of your usual frontline balloon. And depending on the ease, if that balloon goes very easily, then I will not hesitate to use. But generally, I will prefer either angioscult or flextome. And my choice of OPN1C will be the next choice.
Thank you. Thank you. Dr. Bansal, I come to you again. Suppose you have dilated you have placed a stent, there is a residual lesion, you have done maximum pressures with 1:1 balloon, and it's not going away. Would you go higher up more than 1:1, even after imaging?
You might have to use an OPN balloon which will not overexpand, because a conventional NC balloon beyond a certain limit tends to overexpand and produce dog boning, which increases the risk of rupture of an artery. So my choice will be take 1:1 OPN balloon, go up to 25 to 30, and then slowly go up to 40 if there is a need to do so.
Thank you. So that comes to the final question almost, which I'll put to Dr. Ashwin Mehta. The same question which I have asked 10 minutes back.
Yeah.
How to pre-decide which strategy?
Am I audible?
Yeah, absolutely.
Okay. Now, Rajneesh, it will take me a little half a minute or a minute more.
Yeah, sure.
Our final goal is optimal stent deployment. Now, there are 2 points: inadequate expansion and inadequate apposition. Immediate stent malapposition ISMA or a late acquired stent malapposition LASMA, both of them are not attached at all with any event rates. It is the inadequate expansion, minimum stented area. When you achieve 5 or 5.5, I think you are practically done. And I think that you also yourself mentioned to start with. So therefore, to achieve that, definitely plaque modification will be there. Let me start the other way. There are situations in which I would be little concerned about using rota. Marked proximal tortuosity. I'm likely to create a pseudo lesion, pseudo lumen, or even perforation. There I'm scared to use it. There are situations in which the delivery of the rota burr may be difficult because guideliner will not be able to take more than 1.25 burr. If you have to use 1.5 burr, then guidezilla will not work. So therefore, there are situations where you will have to depend upon the other methods of plaque modification. We have 2 more. You asked for scoring balloon and cutting balloon. Unfortunately, the blades of the cutting balloon, the flextome, even in a small length like 10 millimeter and 2 millimeter in size, are sometimes very difficult to deliver when there is some tortuosity. Whereas the scoring balloon is little more deliverable. And apart from that, you can go up to the pressure of 20, 25, 28. Scoring balloon is much more forgiving, and therefore it will help you to. And after having done scoring balloon, maybe you will be able to use the high pressure balloon like OPN NC balloon. Because now, see, I know that the OPN NC balloon also is 0.028. They mentioned 0.016. No, crossing profile is 0.028. So it's a little difficult to cross. But after having done plaque modification with scoring balloon, then you may be able to go and do the things. And I think, let us not go out with the message, Rajneesh. You've been doing rota quite frequently and your threshold is very low. I know about it. Therefore, we must learn and practice and master the technique, because in many situations, rota still may be good to begin with and then to use it. I think rota is very useful. From 1991, it has been existing and it has been consistently stayed and stood the test of time.
So I think this was a very good message in the end, that how we can plan our case. No doubt that OPN balloon has made our lives as an interventional cardiologist much easier and much more comfortable. Now, before the era of OPN balloons, we faced a lot of difficulties with undilatable lesions, which has now become much better and our outcomes have improved. So OPN balloon, I would recommend that all cath labs they should have in their armamentarium. It's a very good tool. And because rota may not be available in smaller centers, rota, again, there is no replacement of rota with OPN, but yes, two becoming together is complementary to each other. So with this message, I think we can end this session. Plaque modification, with all these strategies, one can pick and choose depending on their experience. OPN is a handy tool. So to have best outcomes, we should all use some of the strategies to modify the plaques before putting in stents, and then after stents also if required. So thank you very much. Thanks, Dr. Florin. It was wonderful to have you. It's hot here and we can feel the weather, good weather from Switzerland by you being here. And Dr. Mehta, thank you as always. You were wonderful. Dr. Ajit, thanks very much for your lovely inputs. Lovely having you. And Dr. Uday and Dr. Bansal. It was really wonderful to have all of you as panelists and chairpersons and the wonderful presenters. Thanks for taking out the time. It's a Saturday, it's a weekend. All non-medicals are not doing anything while we are still on, spreading this academic excellence. So thank you very much to all the presenters and all the audience. Thanks once again, and I'm closing the session. But before this, there is a small announcement. Now, after this, since this is the conference, digital conference going on, they're merging the halls, 2 halls together after this session. And then there is some keynote lecture, the Ode to Revolution in Complex PCI. So stay with the forum, and this keynote lecture is just following after this. So on to you, the administrators of this conference. Thank you very much.